Welcome to Health Frontiers, where we explore the uncharted territories of well-being. I am Dr. Robert Lahita, also known as Dr. Bob. With over 50 years in rheumatology and immunology and 17 years as the chair of medicine at 3 major medical centers, my mission is to simplify complex medical issues for you. Join me as we uncover the latest breakthroughs in health, answer your pressing questions, and discuss nutrition and holistic living. This podcast is all about empowering you with the knowledge and tools to manage your health effectively. Let's embark on this transformative journey together. Welcome to Health Frontiers, another episode giving you information that's useful for the management of your health. I'm going to start with the news of the month by talking about relevant things for spring and summer. The first item is tick-borne illness. Everybody asks about tick-borne illness. These are things that you get from being bitten by ticks. And we all know that when we hike or we camp or we play golf and we look for balls in the rough, or even simply working in the yard with the garden, there are diseases that the bite of a tick can cause. And some of them are quite serious, as you'll hear. So I'm going to talk about a few important tick-borne diseases and then talk about how you can protect yourself. So ticks are small arachnids. Those are relatives to the spider family, actually, found in many regions worldwide. They transmit a variety of diseases through their bites. Now, as tick populations increase and their habitats expand, these diseases have become a growing health concern for everybody in the health profession. Among the most common tick-borne illnesses, which we all kind of know about, is Lyme disease. But one you probably haven't heard about is Rocky Mountain spotted fever. There's another one called anaplasmosis, which your doctor knows about, and that's got another name, ehrlichiosis. And then there's babesiosis, and more recently, a very serious tick-borne infection called Powassan virus. And that's a deadly one. It's the most medical practitioners, or I would say, let me rephrase that. Most medical practitioners are aware of tick-borne diseases, maybe not of Powassan virus, but most tick-borne diseases like Lyme disease and Rocky Mountain spotted fever, doctors are aware of. And with a simple blood test, the diagnosis of these illnesses can be made. The most common one is Lyme disease, of course. In North America, Lyme disease is caused by the bacterium we call Borrelia burgdorferi, named after Dr. Willy Burgdorf, and it's the most common tick-borne illness. The primary vector is the black-legged tick. Now, people aren't the only ones that can get infected with this deer tick, as it's called, but also pets like dogs can be infected with Lyme disease. Symptoms begin with a fever, a headache, fatigue, and the characteristic bullseye rash called erythema migrans. Now, the funny thing is, well, I guess it's not so funny, that a lot of patients don't recall being bitten by a tick, and they don't recall the bullseye-like rash. And that can be a problem. There are other patients who remember the rash and remember being bit and actually bring the tick in a little bottle to be examined by their physician. That all helps. But you got to realize that Lyme disease is serious stuff. If it's untreated, the infection can spread to the joints, to the heart, and finally to the nervous system. So the diagnosis is typically based on the symptoms, but also the physical findings, and a history of exposure to infected ticks. With laboratory tests, which we routinely do on lots of patients, especially during the spring and summer months, to see whether the patient has or doesn't have a Lyme disease. There are over 500,000 people will receive a diagnosis and treatment for Lyme disease by the end of this year. So it's a pretty serious item. And how do we treat it? Antibiotics. Very, very easy to treat, particularly the antibiotic doxycycline. And that's the standard treatment, but your doctor may talk to you about other kinds of treatment. The next disease is Rocky Mountain spotted fever. It's not so common. The American dog tick, which is the Rocky Mountain wood tick, primarily seen in the western states and sometimes in other parts of the country. And it's called the brown dog tick, transmits this Rocky Mountain spotted fever. It's caused by a bacterium, named Rickettsia rickettsii. It's been around forever. Symptoms include fever, rash, headache, and muscle pain, and it can become severe or fatal if it's not treated promptly. Most physicians know what to look for with regard to Rocky Mountain spotted fever. Early diagnosis and treatment with doxycycline, again, are crucial for preventing serious complications. Then there's anaplasmosis, which is better known as ehrlichiosis, and that's caused by another bacterium called Anaplasma phagocytophilum, and it causes this disease and transmitted by a black-legged and western black-legged tick. Its symptoms can range from mild to severe and include, again, fever, headache, chills, muscle aches. Doctors diagnose anaplasmosis through clinical symptoms and confirm it again with laboratory tests. Again, the treatment is usually antibiotics like doxycycline. An interesting fact about this is it's not so rare. I was giving a lecture on Shelter Island, which is at the very tip of Long Island, for those of you who do not know this area. And I was giving a talk and went to a lawn party after the talk, and I noticed that half the people on Shelter Island were marching around with crutches. So I went up to one of the ladies with crutches and I said, "What's going on?" And she says, "Oh, it's Ehrlichia. It's endemic on the island." And it was. And it's better known on islands at the tip like Shelter Island, Northport, the South Shore of a place like Shelter Island or Long Island, and of course in Rhode Island and in Connecticut, which borders the Long Island Sound. It can be found. It's also common in the Hamptons, which is a very, very big location for vacationers in the summertime. So you have to be aware of ehrlichiosis or anaplasmosis. The next disease, which is also very unusual sounding, is babesia. Babesiosis is a malaria-like illness, very interesting, caused by a parasite called Babesia parasite, and it's also transmitted by the black-legged tick. Symptoms can vary from mild disease to very severe disease and include fever, chills, sweats, headache, body aches, nausea, fatigue, terrible symptoms that can go on for days. In severe cases, however, with babesia, it can lead to hemolytic anemia. That means where the blood cells pop as a result of an immune reaction, and you can become very, very tired and very, very anemic. And organ failure can ensue, and that makes it extremely serious. Doctors make the diagnosis again through blood tests, and treatment typically involves a combination of antiparasitic drugs and antibiotic medications. Now, the New York Long Island shoreline, such as Fire Island, which is a popular destination for a lot of people, for example, primarily harbor babesia in the summer. You got to tell your doctor about your summer locations when you go to see him or her. They're going to ask you, where were you this summer? Why would you have had a tick bite? And of course, that's an appropriate question, but it helps when you tell them, well, I've been out on the tip of Long Island, or I've been in the South Shore, Fire Island, or I've been in Southern Connecticut, etc. These summer locations help us make the diagnosis and help us choose the appropriate therapy once we do the proper lab tests. The last tick-borne virus that's really important is the Powassan virus. The Powassan virus is very rare, but it's a serious tick-borne disease, and it's transmitted again by the black-legged tick. And the groundhog tick is another vector. We call these ticks vectors, means they're the ones that wind up biting us and causing the disease. Now, the symptoms can range in Powassan from a mild flu-like symptom to severe encephalitis and meningitis, which is an inflammation of the coverings of the brain. Encephalitis can be quite severe. Behavior is altered. Patients behave as though they've got meningitis. They become somnolent and in some cases unresponsive. Now, the problem with Powassan virus, which was recently in the news, is that there is no therapy. So if you get Powassan virus, your chances of suffering some severe symptoms and possibly even death are fairly large. Now, how do we prevent these tick-borne diseases? Well, you got to expose yourself in order to get bitten by a tick. So prevention of exposure to ticks really helps. So some of the strategies are to avoid ticks, stay on trails when you're out in the woods, avoid tall grass, bushes, wooded areas that commonly harbor these ticks. Want to use a tick repellent, something like DEET, D-E-E-T, which is an insect repellent. Another one is permethrin, and apply that to your skin and clothing. And you can get these in you don't need a prescription for these. You can get them in camping stores, camp goods stores, especially if you're going camping and you're going to be living in the woods in a tent. You want to wear protective clothing like long sleeves, long pants, and you want to tuck the pants into your socks to minimize skin exposure. Conducting tick checks are really important. After spending time outdoors, and this goes for men or women playing golf as well, you examine your body and examine your pets for ticks. Promptly remove ticks using a fine-tipped tweezer and save them, as I mentioned, for your doctor, who will confirm the diagnosis. Now, to be honest with you, your doctor may not know what the tick looks like, but he can take it to the lab, and in some states, the State Board of Health will provide identification for the ticks that you save. Maintaining yard hygiene is really important. Keep the lawns mowed, remove leaf litter, and create barriers with wood chips or gravel between lawns and wooded areas. So in conclusion, we're talking about tick populations, and they're continuing to rise. And this is a problem. So you're being aware and using preventive measures are critical in reducing the incidence of tick-borne diseases. Again, early detection and prompt treatment are essential for managing these infections and minimizing their impact on your health. By understanding the risks and taking the appropriate precautions, individuals can protect themselves and their families from these dangers posed by tick bites. And this is a big problem. It's not something that's rare. The next item we're going to talk about before we introduce our guest, this item is about full bloom in spring, allergies versus the common cold. And I'm always asked about this. The spring is in full bloom right now, and I go out to my car if I leave it outside and don't put it in the garage, and then on the windshield is this green film. And you have to actually turn on the windshield wipers and wash the front window to get the green film off. It's very common if you're in a very, very wooded area. If your house is in the country, it's particularly common right now because we've had a wet winter, a lot of rain in some parts of our country, a lot of flooding. And this just adds to the chances of you getting sick with an allergy. So we'll embark on a journey right now to talk about concerns. As the seasons change, our health needs change. In April, for example, and in May, the common health concerns include allergies, springtime colds, and the importance of maintaining an active lifestyle. So there are some practical things to consider. Allergy management is really important. Spring is synonymous with blooming flowers and heightened allergy symptoms for many. Now, there are also allergies that occur in the fall when the leaves are falling, and ragtime is more common in the fall. But in the spring, with all these flowers blooming, this is really a big issue. Identify your triggers, and that means knowing what causes your allergies, because the allergy comes on quickly. It's not something like the common cold, which takes 2 days to develop. Scratchy throat, runny nose. We all know what that's like. That's a viral-caused illness. Being in the cold, by the way, or having your feet wet or not wearing a jacket in winter is not conducive to getting a common cold. Common colds are caused by viruses. Allergies are caused by triggers that come from plants and trees. And common triggers include pollen, mold, and indeed dust mites. And dust mites, probably in your house, in your carpets, they're all over the place. But at this time of the year, you can really get very irritated. Over-the-counter antihistamines and nasal sprays usually provide relief for allergies. For severe allergies, you should go to an allergist, consult your doctor for prescription drugs. There are many over-the-counter medications that are used by patients daily, and I'm not going to recommend a particular brand because that would not be fair to most manufacturers. But if you go to your neighborhood pharmacy and you ask your pharmacist, give me a good allergy medication, he or she will recommend a very good over-the-counter, inexpensive medication. What about the environment? Well, control your environment by keeping your windows closed during the high pollen days. Use air purifiers and regularly clean your living space to reduce allergens. Your air conditioner builds up many of these foreign substances called allergens during the winter. And so when you flip them on in the summer, when things start to get humid and hot, blam, you turn it on for the first time, you smell kind of a funky odor. And it could mean that you have mold growing in your unit. And if that is the case, look out. You're going to be congested. You may even have a sore throat, and you may be coughing a lot. That is the first sign of an allergy. What about springtime colds? I mentioned the colds before. Well, the transition from winter to spring can leave people vulnerable to colds. Remember that cold weather does not produce colds, as I said, but colds come from viruses transmitted from person to person. So why do we get colds in the winter and not so much in the summer or spring? That's because the nasal passages get dried out, more conducive to viral infection. So as your nasal passages are dried out, you tend to have viral infection if you're in contact with somebody who has a cold. Now, being in contact doesn't mean they have to sneeze all over you. You can be on the subway and touch a pole that somebody with a bad sniveling cold has, and you will now have the virus. It'll get into your breathing space, and a common cold is transmitted. It's usually from person to person. We don't get colds from our dogs and cats. So what about some tips to help us with the common cold? Well, the most important thing is to probably drink plenty of water to maintain your body's natural defenses. Because as I said, if your mucous membranes are dried out, you tend to be infected easier. So 3 to 4 liters of water per day is a good idea. Rest and sleep. In one of our previous programs, we talked about sleep deprivation, which is extremely common in our society. People don't get enough sleep. And if you're in a war-torn country, in Europe or in Africa, for example, you don't get any sleep because of bombs going off. You're anxious about what's going to happen next. So that really does not allow your body to recover and function at its peak. So you should be getting 6 to 7 hours of sleep on a workday and more sleep on the weekend. What about nutrition? Well, I recommend that everyone eat a balanced diet rich in fruits and vegetables and whole grains to support your immune system. In future programs on Health Frontiers, we're going to have some nutritionists and some people to talk about alternative medicines and dietary means of upping your immune resistance. That should be very important. And I welcome you to stay and watch Health Frontiers and see some of the programs, which are usually able to be downloaded on YouTube. What about exercise? Oh, that's a big one. Regular physical activity enhances your overall health and provides your immune function at peak levels. Believe it or not, a good workout really is the best thing for immune resistance to infection, and also helps you with allergies because most gyms have air filtration systems in them that prevent pollen and other allergens from dealing with your immune system, your mucous membranes. With warmer weather, it's a good idea to walk about a mile each day if you're an older individual and do not consider yourself fit. Or if you are fit, run at least 3 miles per day or every other day. You don't have to do it daily, as I mentioned, but every other day or every 3 days, as long as you adopt a program that you follow. That's very hard. At New Year's, we all have our resolutions, and everybody's buying a bicycle stationary for their apartment, or they're getting a treadmill, and they, in a 1 month, wind up being clothes hangers. That's not what we want. You want to be able to go on the treadmill or go on the bicycle every day or every other day. Set a goal for yourself, and you'll be amazed at how healthy you'll be in about 3 weeks. You don't have to do it daily, as I mentioned, but you can stagger your workouts. The stamina for that is not present in everybody, so everything is gradual. So, somebody comes to me in my office and says, I love to run 3 miles a day, but I'm really out of shape. Well, here's what you do. You run a half a mile one day, you run a mile 2 days later, you run 2 miles maybe a week later, and eventually you're up to 3 miles without a lot of pain, because it's tough to just go and start running or start bicycling for that matter. What we don't want is to have that as either a floor mat, or I shouldn't say a floor mat, or a clothes rack in your apartment or in your house. So that's all that I have to say about allergies and the common cold. And you can write to me at askdrbob@healthfrontierspod.com. Again, that's askdrbob@healthfrontierspod.com. Now, one last point, a question came in from a lady who was watching the show. Well, several questions actually, and this is about bone health. And bone health is really a very relevant topic today, especially in you ladies who are postmenopausal, that you've had your menopause. And we're going to hear today from a urogynecologist in a few moments. But what about this question? I had my hip replaced, and I was told to take vitamin D to build bone and aid healing. Is this true? What's this all about? This patient writes. Well, the existing guidelines on the use of vitamin D, which, by the way, in the journal JAMA just recently, like last week, had a big article, which I think I brought here, talking about vitamin D and the immune system. It's excellent as far as improving your immune function and host resistance. So if you're low in vitamin D, and most of us in the Northern Hemisphere who don't go out in the sun very much during the winter months, we tend to be low in vitamin D because vitamin D is metabolized, believe it or not, in our skin. So we can take vitamin D, but the existing guidelines on vitamin D and its benefits in improving outcomes after surgery are not really clear. This is a good statistic. The USA annually, get this, has 549,000 hip replacements and 790,000 knee replacements. Can you imagine the insurance companies paying for that? Or in addition, some places they don't take insurance and you have to pay out of pocket. But those are a lot of surgical replacements, a lot of artificial joints. By 2060, the aging population will increase these numbers to the millions of knee replacements, millions of hip replacements, and most of it is being done robotically. That means we can increase the numbers and we can do it safer. So vitamin D helps the body absorb calcium, which strengthens bones and can reduce inflammation. Both are important in the recovery period after your hip surgery. For this lady that wrote this, there is something called periprosthetic fractures that can occur above or below the implant, for which vitamin D status could be significant. This is crucial in those people who have osteoporosis. And a lot of elderly, particularly women, but also men, a lot of elderly postmenopausal ladies have osteopenia, which means lowered bone growth and lowered bone strength, or osteoporosis, which is actually a clinical condition that needs to be treated with medication. People who are elderly and not in terrific shape are also subject to falls. And the complication rates after transplantation of a hip or of a knee are significant because of the frailty. People older than 70 years of age who are undergoing joint replacements should have a bone mineral density done, called a BMD, before surgery if they have not had one in a 2-year period. And most doctors that I know, family doctors as well as internists, will recommend that you get a bone mineral density. Now, here's another question. I am a woman 60 years of age and well past my menopause. Should I have a bone density study? And the answer is yes, you should. The lowering of estrogen or female hormone levels risks softening your bones or causing them to lose calcium and what we call bone matrix. That's the stuff upon which the calcium sits. A bone mineral density is easy. It takes a couple of minutes to complete, and your doctor can order it like that. Your doctor will then have a readout about whether you have osteopenia, a reduction in bone density, or osteoporosis, a condition, as I mentioned, in which you have lowest bone faster than your ability to make new bone. It's important to treat these abnormalities before you suffer a fracture, not after you break your hip. And if you're in your 80s or 90s and you break a hip, that's big trouble. Why? Because you don't heal as well, and it's very hard to recalcify bones that are very, very osteoporotic. We do have ways of doing it, but you have to be under medical care, hopefully with a rheumatologist or an endocrinologist, to have that happen. Now, here's a question from a male. He asks, does osteoporosis occur in men as well as women? And the answer is yes. As man ages, genetics, lifestyle choices can cause him to lose bone, just like a lady. Now, the loss of bone really occurs in males who are not very active. A man or woman can lose bone if they have been on medications like cortisone, prednisone. Drugs to treat the allergies that I just spoke about can cause you to lose bone. That's why we're not big fans of cortisone unless you absolutely need it. Some families have a predisposition to bone loss hereditarily from an early age, and the doctor should be told about this when he does your physical. There are people who are known to have bone loss, and they have brothers and sisters who have had bone loss in their 20s and early 30s. So those families have to tell the doctor, hey, I've got a hereditary loss of calcium. I think the last question we have here is from a man. Does lack of testosterone cause bone loss in men? Now, a lot of guys talk about low T. Low T being, I have low testosterone. And we don't know whether they do or they don't until you actually get it measured by your doctor in the laboratory. But low T can be a cause of fatigue, weakness, inability to really hit that golf swing or that baseball bat with good energy. Low levels of the sex hormones, testosterone and estrogen, men have estrogen too, and estrogen in men, believe it or not, is probably more important for bone growth than testosterone. We just have lower levels than women. But nevertheless, a major loss of bone can happen in a man. And unhealthy habits, particularly guys who go out and have 5 or 6 drinks a night or drink a case of beer, they're likely to have more bone loss than men who don't do that. Also, smoking, extremely bad. Smoking is bad for osteoarthritis, for osteoporosis, for osteopenia, as mentioned. It's also bad for your hormone levels. So smoking and alcohol are a major cause of osteoporosis in men. And you need to know that. And if you're a lady watching and you want your boyfriend or husband to know this, go ahead and tell him, and I'll attest to it. Weak muscles and being over 70 years of age, again, are also reasons for men to lose bone. Now, the last point I want to make is that cancer treatments and medications that you have to take can also contribute to the loss of bone. And if you're worried about it, get a bone mineral density. It's fast, it's cheap, and your doctor will be happy to order it for you. So that's my 30 or so minutes of news for this podcast of Health Frontiers. And now I'm going to introduce my guest for today, and let me have him come into the studio. I'm very happy today to have a guest with us, Dr. Ali Ghomi, who is the chief of urogynecology at St. Joseph's Health, which is St. Joseph's Medical Center here in New Jersey. Now, I have to tell you all that I know very little about urogynecology, and that's okay because most of my colleagues know very little about it as well. So we're relying on Dr. Ghomi to fill you in as patients, and perhaps you will see him as a specialist for treatment of urogynecologic problems. Welcome, Dr. Ghomi.
Thank you very much, Dr. Lahida, for having me.
It's a great pleasure. So let's start off and have me ask, what exactly is urogynecology?
So urogynecology is a specialty that deals with disorders of pelvic floor, specifically the disorders of the bladder and the rectum, specifically in the female population.
Okay. And I imagine from what I've heard among my patients and others, that that's a fairly well-known and common problem and brought on by things like pregnancy, carrying, does multiparous or having many children predispose one to problems like
Absolutely. So the way I explain it to my patients is it's a matter of weakness of the support of the structures that hold the bladder and the rectum and the uterus and the vagina together. And most of the damages do occur at the time of childbirth. So the conditions that affect the bladder support, the rectal support, the support of the uterus and the vagina, they do end up being the culprit behind the disorders of these organs.
Is it safe to say that most of the pelvic pain that a lot of women have is urogynecological and can be remedied by surgery?
Correct. Now, pelvic pain is rather complicated subject matter, especially in the female population.
Yes.
We all remember from being medical students and residents, the list is long and hard to remember. But just to summarize, when you see a patient with pelvic pain, for example, which is rather common, the age of the patient is highly important.
That's important.
It can happen to a patient who's never had children. So then you have to think about what are the possibilities for that individual having a pelvic pain versus a 65-year-old who's having pelvic pain. So then you can focus the attention on the treatment and further investigation.
I see.
Now, just to summarize and simplify potential etiologies, the way I explain is musculoskeletal etiology is highly common.
So etiology for our audience means cause.
Correct. So anything as simple as sports-related injuries that might have happened a few years prior to the presentation of the pain could lead into pelvic pain. So if I see a 20-year-old athlete and all of a sudden they have this nagging pelvic pain, and they have seen a number of specialists, they have seen a primary care, they have been sent to an orthopedic specialist, and nobody can exactly figure out what's going on. And after a number of evaluations, physical examinations, eliciting history, one might suspect that this is a musculoskeletal pain in nature that has become chronic. And then we might utilize our pelvic floor physical therapy colleagues. We get them involved to isolate the muscles, to give them certain exercises, to put them through rehab, a course of treatments that can hopefully result in relief of their discomfort.
That's amazing. I'm actually amazed at this because there are physical therapists that just deal with the pelvic floor of females.
Absolutely. So these are the physical therapists that have gone to school. They have become physical therapists. They have done further training just specifically on female pelvic floor disorders. And they're a gem to have. They're fantastic. I utilize them. They're hard to find. But most healthcare providers are not aware that they are available.
Yes, I was not aware of that, actually. And I've had patients with pudendal, and pudendal means crotch, pain and discomfort. And they come to me or they go to an orthopedic surgeon because they think it's from their back.
Yes.
And it could be from the back, I guess.
Yes.
But this is an ongoing and can be a nagging problem.
It could be debilitating.
Debilitating with regard to relationships, for example.
Correct.
Sexual intimacy.
Absolutely.
These are all the things that we as physicians hear about. So you get to see them and figure them out.
I get to see them. And the other category is, for example, while we're on the subject matter, pudendal nerve, ladies who have had prior surgeries. Mm-hmm. There could have been impingement of that pudendal nerve by a suture that was placed in the vicinity of that nerve.
Wow.
That nobody made the connection.
Yes, yes.
And those patients are out there. Unfortunately, the condition is delayed diagnosed, and as a result, delayed treatment is not uncommon.
Boy. And they're miserable.
And they're miserable.
Oh my gosh.
Yeah.
And so this is a very, very important area.
It is.
Which is rarely spoken about. And I have to say this because running the podcast, I have not heard about urogynecology, but I know some specialists who have said, oh, send that patient to a urogynecologist. Right. Well, here Dr. Ghomi is the man.
Right. So pain is a big category, obviously, right? And then the other category is the bladder.
Mm-hmm. Incontinence, for example.
Correct. Leakage of urine.
Wow.
So conditions that has to do with the storage of the urine and voiding of the urine. Mm-hmm. And that's a kind of, to put it simply, storage has to do with the incontinence. So the patients typically loses urine with activities, with coughing, sneezing, going to the gym. Mm-hmm. Then the opposite side is the conditions where the patient has to go often. They have to go to void every 20 minutes, every hour.
Terrible.
They get up at night every hour. It's called nocturia, 3, 4, 5 times a night. And that not only can hinder, you were speaking of sleep deprivation.
Yes.
That can significantly interfere with your sleeping cycle.
Yes.
Big problem. And during the day, that can interfere with your work, with your functioning, with your activities. It can impact your social gathering. You're less likely to go to a restaurant or to go to a social event if you feel like you have to go, and empty your bladder frequently.
This is a colossal issue.
It is a big issue.
That's amazing. Now, is there an age range that you mentioned athletic women, and obviously that's a younger group like marathon runners, people who are gymnastic,
right?
People who ride bicycles, like stationary or mobile bikes. You must see all of those.
All of them. Yeah. All of them. I get to see them from, as you said, athletic younger patients to older individuals, postmenopausal patients. So they have different types of different varieties of these categories.
Yes.
The etiology, the pathophysiology of these conditions are slightly different on the younger population versus the older.
Yes.
But ultimately, it all funnels down to how the bladder or the rectum or the vagina or the uterus are functioning.
Right. Now, does this kind of a condition, if a woman has this and she's like 25 and she's anxious to have more children, say she's had maybe one or two children and she's anxious to have more, this would be an impediment to getting pregnant again.
Correct. So now, luckily for a 22-year-old, for example, even with having two kids, the damage to the area has not been long enough to manifest in incontinence. Fortunately, in extremely young patients, ladies in their 20s, this is typically not a problem as far as the incontinence is concerned. But if you're dealing with a 40-year-old, for example, and right now a lot of patients are delaying childbearing or they want to grow their families, that might become an issue. So one of the common questions is that OBGYNs face, for example, and seek a consultation is, I have a 35-year-old who already has urinary incontinence. She wishes to get pregnant.
Yes.
What would be the mode of delivery for the child?
Oh.
Should we have a vaginal delivery or should we have a C-section to protect the area from further damage?
I see.
So as you can see, there's a connection between, obviously, the childbearing and the
you
damage.
can render that opinion based on your exam.
Based on the exam. So you can assess the degree of the damage already.
Yeah.
By how mobile, how weak the musculoskeletal support for the area is.
So you must have defined ways of doing sort of a mini neurologic exam as well as evaluating muscle.
Correct.
Which is very specialized. I can't imagine a regular internist or orthopod or a rheumatologist really figuring out what the problem is.
Correct. Yeah, experience is the key. You have to know what is normal, what is not normal for that age group.
Yes, yes.
So, and again, another thing that I see all the time, I get patients that are labeled with having, for example, a cystocele, which is dropped bladder. And I examine them and I'm like, no, you don't have a dropped bladder. Just relax. So experience definitely plays a part in that to kind of assess and accurately diagnose the right condition.
Yes. Now, does obesity play a role with these issues?
It's debatable. Obviously, the connection is in the obese individual, you have more pressure built up inside the abdominal wall. Inside the abdominal cavity. And that pressure is going to get transmitted to the pelvic floor.
Yes.
So if one has some degree of weakening of the support of supportive structures, if the pressure inside the abdomen is constantly increased, it's just going to put more pressure on the organs and therefore more likelihood of incontinence or prolapse.
Yes, yes.
But the research, it's not that clear cut on that subject matter.
Okay. What about smoking? What about things that we worry about with regard to female health? Patients that say smoke who are now in their 60s, perhaps early 70s. What about dietary influences? There's a whole bunch of things that come to mind.
Yeah, great. So the way I educate my patients is by telling that to look at what that activity, such as smoking, might do to the health of the tissues at the level of the pelvic floor. So if the smoking, for example, would compromise the blood supply, and the compromise in blood supply would translate into weaker muscles, weaker connective tissues, then they would be more likely to experience prolapse.
Which is a biggie.
Right. Obviously, diet, it's very easy not to intake adequate amount of protein, and that might have an impact on the health of the connective tissues and the musculature of the pelvic floor. And on the other hand, exercising. Highly important.
Very important.
Very important. The more you exercise, the more you can maintain the muscle tone of all these muscular structures in the pelvic floor that are supporting these organs in place. And that's where physical therapy comes into play. Essentially, to rehab these muscles so they undergo hypertrophy or growth, their tone would increase, And as a result, they can maintain these tissues in locations where they belong,
Yes.
as opposed to out of the so-called the comfort zone.
Right. Now, there are no doubt exercises that you prescribe that the patient should do, because I'm thinking of things like the Rockettes, dancers, people who do gymnastics and acrobatics. A lot of women are superb at that,
Right.
but they must have a higher risk for damage to the urogenital tract.
Correct, especially after injury.
Mm-hmm.
I see horseback riders, snowboarders, if they land on their tailbone
Yes.
due to accidents,
Yes.
there could be a micro tear at some of these muscles or some degree of injury to the nerves that innervate these muscle groups. And over time, over 5 to 10 years, the manifestation might be what we're talking about. So always when I see a patient with these type of conditions or symptoms, they come to me, I always ask them, did you play sports in high school? Did you ever do skydiving? Are you doing skydiving, landing? I mean, that's where you can get the micro tears.
Wow.
So I have seen a number of gymnasts because of constant
You've seen
landings.
everything. It's really amazing.
The landings and skiers, snowboarders. So anybody who's prone to having some sort of a sports-related injury involving the pelvis, you automatically know that in the long run, they might have to deal with some of these issues that we're discussing.
That's extraordinary. Now, obviously, you do urodynamics.
Yes.
Which is a way you could explain to the audience, what is a urodynamic analysis?
So urodynamics is a relatively simple test where the physician would objectively measure the way the bladder functions, specifically the way the bladder stores urine and empties urine, because that's all the bladder does. Bladder is an organ for storage of the urine, and when socially acceptable, empty.
Yes.
So the study is designed to objectively measure that, how well the bladder is storing, where some of the issues might lie, and how well the bladder empties, and which would be incontinence.
Yes.
So by inserting tiny catheters into the certain areas, connecting those catheters, which have pressure sensors at the tip of them, to a computer software program, we gently fill the bladder up with water, and we put the patient through a simulation as if the bladder is filling up, and then ask the patient to empty the bladder to try to discern where the problem might be. Because sometimes we have a saying, we say bladder is a poor witness, i.e. when the patients come to us and they tell us what's going on, that might not be exactly what's happening. So urodynamics kind of puts an objective spin on the symptoms of the patient.
Amazing. And what about imaging?
Not that helpful.
Not helpful.
Helpful.
Not probes, ultrasound probes, or
not really. Unless there is, for example, a big pelvic mass or a big uterus or a big ovarian cyst has grown in the body without causing much symptoms to the patient, but the mass is sitting on the bladder. And therefore, the bladder has to empty often. So we call that mass effect. There is a mass sitting, pressing on the organ, and the organ tells the brain, hey, I got to go empty.
Right.
So other than that, and that can be easily picked up during the physical examination, I mean, this is nothing subtle.
Yes.
So usually it should be an ovarian mass bigger than 5 or 6 centimeters, or uterus, what we have, 15-week size, which is about 5-month pregnant uterus.
Right. Wow. And so we've talked about bladder training, physical therapy, which is very specialized. Are there surgical procedures that can be done ultimately to fix this?
Absolutely. Yes. So it really depends on which condition we're referring to, but let's just pick, for example, urinary incontinence.
Yes.
So the mainstay of treatment is non-surgical. So we always do physical therapy first, or offer physical therapy first. And if physical therapy is not effective, or the patient is not fully satisfied, the surgery comes into play. And the surgery is essentially intended to restore the support of the what we call bladder neck. That's an area that allows the bladder to open up and therefore the urine to come out.
Right.
These surgeries have been around for 50, 60 years, but now over the past 20 years, they have become so minimally invasive. They can be performed literally in 10 minutes under general anesthesia with very fast recovery. So it has completely revolutionized the treatment of stress incontinence in the female population.
Wow. Yes, I could recall as a child or as a young man, relatives having had their bladders lifted.
Right.
And these big incisions and all this stuff. So
big incisions and the catheters for days to a week.
Yes.
They would stay in a hospital for 2 days.
Oh.
The surgeries. I mean, I participated in some of these during my training.
Yes.
And looking back, it's amazing how much we have evolved.
Yes.
When it comes to these minimally invasive procedures in all fields.
Yes.
I mean, literally, we can be done sometimes in 6 minutes.
Which is amazing.
And which is amazing.
It is amazing.
Which is amazing.
It's truly amazing.
Yeah.
And my other question is medications.
Medications,
yes.
Absolutely. So we briefly discussed the group of patients who have frequency and urgency.
Yes.
They feel like they have to go all the time.
All the time, which is it's got to be a real bear.
Yes, it can be quite debilitating.
Yeah.
I mean, it's so much so that in very rare situations, the patient elects to have their bladder taken out and put a bag on their abdomen into which they would urinate.
And in certain areas of the country where there are no urogynecologists such as yourself, I'm sure these people suffer intensely for a long period.
Correct.
Yeah.
So for this condition, which is commonly referred to overactive bladder,
yes,
medications are mainstay of treatment.
Right.
And the medications essentially is intended to relax the muscles of the bladder, to take away the messaging from the bladder to the brain. Because essentially it's the brain that ultimately tells the patient that they have to go. So if somehow we can relax the bladder with these medications, we can overcome a lot of the symptoms for the patients.
Wow. Incredible. There are no doubt innovations, as you've said, and advancements. Is much of this done robotically at all?
Correct. So some of these are done robotically. So robotically is done for what we refer to as pelvic reconstruction. So sometimes as a result of having multiple childbirths and certain genetics, all these organs are completely out of place. The bladder is coming out, the uterus is coming out, the support of the rectum is compromised. So you need to reconstruct, and put all these organs where they belong. That's where the robotics come into play. So prior to the robot, these procedures were done through the vagina or through the abdomen. And over the past 15 years, we have found a way to do these robotically. The concept remains the same. The procedures are the same as when they were described, let's say in the 1950s or 1960s.
Yes.
But the way we get into the abdomen to do them is through these keyhole incisions with the help of the robotic arms, and much more precise and obviously faster recovery for the patients.
Yes.
So robotic definitely has a role in this.
Well, most patients don't realize that, but we have had a surgeon here prior who was a bariatric surgeon talking about robotics in the treatment of fat removal. But now this is seemingly very precise surgery to correct what is a common problem among women, both young and old.
Correct.
Where there is incontinence, where there's pain, where there's all sorts of prolapse of pelvic organs, etc. And to know as patients, and I'm looking at you all as patients that you're watching, that a specialist like this exists is exceedingly important. And to tell your doctor that specialists like this exist, because I'm sure in parts of the state, in parts of the metropolitan area, these patients cannot avail themselves of a specialist like yourself because they don't even know that you're around.
Correct. And sometimes the healthcare providers are not aware
exactly
how to connect the patients to the right specialist.
Exactly. It's extraordinary. So encouragement is really major from this interview. You are a major resource for women. Is there ongoing research in this area now?
Absolutely. So any type of condition when you look at, for example, medical therapy, right? So medical therapy, one of the downside is side effects.
Mm-hmm.
So these medications typically cause dry mouth, constipation, blurry vision.
Yeah.
These are the class of medications commonly referred to as anticholinergics.
Right.
But they have evolved and the side effect profile continues to get better and better.
Wow.
When it comes to surgery, the surgery is all about how can we do these less invasive?
Mm-hmm.
How can we increase the longevity of the repair? Mm-hmm. What type of material we should use to minimize to minimize the complications.
Yes.
So all these fine tuning, so the expectations change. It's more than just doing the procedure. What's going to happen 5 years from now? What's going to happen 10 years from now to that patient? What kind of longevity of repair are we talking about?
Well, once there is a repair, is there any difficulty conceiving and having children after such a repair?
No, there's not.
There's not.
There's not. I mean, divorce
should be done and it's very safe.
Correct. The question remains whether the repair would be compromised once the delivery takes place.
Right. Right.
Just because of the forces.
And you just then have to reevaluate.
You have to reevaluate.
Yeah.
I mean, you can never tell the patient not to go on and have more kids, right, if that's what they wish to do. But they need to be appropriately counseled about the risks of going down that path.
Yeah. Wow. This is extraordinary. I find this fascinating. Is there anything that you'd like to say in conclusion or anything that we haven't covered?
Sure. No, I think in summary, the patients need to know about pelvic health, about pelvic floor, about these conditions so they can bring it up to their healthcare providers to know that if they suffer from some of these conditions, they can be mitigated. They can be either corrected or they can take some medications to improve their quality of lives.
Mm-hmm. Really amazing. Well, I want to really thank you for such an enlightening interview because this is something that we don't readily talk about very often. And in fact, it's an area that I had no idea was so defined and so hopeful for women out there who have these urogynecologic problems. And so I really want to thank you, Dr. Ghomi, for coming. And again, if you want to ask more questions, go to Ask Dr. Bob at healthfrontierpod.com. That's our selected email just for this program, and we'll forward any of your questions to Dr. Ghomi, or you can reach you directly through the St. Joseph's Health System. And I'm sure in the state of New Jersey, you're in the physician directory, et cetera.
Yes.
That'd be terrific. So again, I want to thank you all for watching today, and I hope this has been an enlightening experience. It certainly has for me. Thank you again.
Thank you.
Thank you for joining us on Health Frontiers. I hope today's episode provided valuable insights into your well-being. Remember, this podcast is not a substitute for professional medical advice, but a source of knowledge and guidance. If you have any questions or topics you'd like us to cover, please reach out. Make sure to like, subscribe, and visit our website at www.healthfrontierspod.com. Join us next time as we continue our quest to uncover the latest in health and wellness. Stay healthy and empowered. Until next time, I'm Dr. Bob.